Welcome to the Generous Benefits Podcast, where we help employers create meaningful, people-first benefits that make a real impact. Today, we're demystifying hospital billing with Dr. Kevin Stevenson, a board-certified healthcare executive that has led strategic operations in multiple systems, bringing the broad view of hospitals and how they actually function. I'm your host, Amanda Brummett, and I actually come from hospital administration too. My goal today is to help employers understand what's behind the bill so you can make smarter decisions, ask better questions, and build stronger partnerships with your local hospitals, who aren't your enemy despite what you may have been told. In this episode, Kevin breaks down how pricing and payments really flow and shares practical ways employers can work with hospitals to improve cost, access, and member experience. Well, Kevin, thank you so much for being here. I am so glad that you carved out a little bit of time to come educate us all about hospitals and how they bill. I've actually been wanting to talk about this topic for a long time, and you were definitely the person I wanted to talk to about it since you've worked in so many health systems, and you're also one of my few people that were part of ACHE North Texas and now ACHE Central Texas. So, it's different between the different markets and gives you a lot of perspective.
Well, and not only these two markets, but in my career, I've been blessed to have been in 4 other states. And so every state has its own nuances, particularly the one that was the biggest difference was obviously Louisiana about 25 years ago, because Louisiana healthcare is unlike anywhere else in the country. I was at a large, successful community hospital in Baton Rouge. And the problem was the state charity hospital that was about 3 or 4 miles away from our large hospital, they ran out of money mid-year. And oddly enough, state hospitals, if they run out of money, they can shut down.
Yeah.
And so we went from a manageable 6 to 7% uncompensated care rate to 13% literally overnight. And so you can only imagine what that does to hospital finances and really the overall strategy. Everything goes out the window because now you're just trying to survive.
Yeah. I think hospitals get a bad rap in the market and they think they're the big bad guy. And if they really knew that hospitals are just trying to keep their doors open so that they can serve the community. But before we get into hospitals, I'm getting ahead of myself. I've told people a little bit about who you are, but let's hear it from your version. Who is Kevin Stevenson personally and professionally?
Started healthcare a little over 36 years ago. It was actually my second career. We were in Little Rock at the time. Our Sunday school teacher happened to be the president of Baptist in Little Rock.
No way.
The largest system in the state. I basically started the business development and marketing function for the 162-bed freestanding rehab hospital. And so from there, started getting recruited to different hospitals, came back to Texas, was in Old Harris Methodist Fort Worth, now part of Texas Health Resources. And so was there for about 4 years. And that's where I got my taste of operations and really enjoyed that. And so, did something I never thought I would do. I got recruited by a for-profit hospital across town.
Ooh.
And went over there and found out, this was a great move. It was a great hospital. Every hospital is dependent upon their leadership and particularly the president. That sets the tone for the culture. And we had a great one. And about a year and a half later, corporate came and said, we'd like to promote you to CEO of a small hospital in Kentucky. And I'm like, I'm 35 years old. You can't say no to something like that.
No.
And so spent about a year and a half in Kentucky, went to Nebraska with the Catholic system. Loved that. One of the big things there was we were part of Catholic Health Initiatives, now Common Spirit. You'll see a theme. I've been around so long, names keep changing. And got recruited again, went to Baton Rouge, as I said, spent some time there, went through some really interesting financial times. Wasn't there very long, unfortunately, because of that. And they got brought back to the Dallas-Fort Worth area where I was at Old All Saints in Fort Worth as Baylor was purchasing it. And so I helped that transition. So the position came up in Waco. My wife and I both graduated from Baylor. We had always talked about coming back here. And so we jumped at the chance. And so that's what we did. And spent a little over 5.5 years in chief operating officer role here, and really loved it. Made the decision a couple of months ago, it's time to do something a little bit different. And so I've kind of stretched my wings and doing more advisory consultative type work. Personally, been married for 38 years. We have 2 daughters. Our oldest daughter's married and lives in Charlotte, North Carolina, and just gave us grandchild number 2. We're real excited about.
Wow.
And our youngest daughter lives here in Waco.
Well, let's jump into hospital prices.
Okay.
They're super high. We all know they're super high.
Yeah.
I think what the rest of the world doesn't know is hospitals are playing the same game that everybody else is. So can you explain why the prices are so high, and then what actually matters? What matters for a human that is getting that bill, for an employer that's paying that bill?
Yeah, glad to. And Amanda, you're right. Most people, they see all these giant buildings and all this technology that hospitals invest in, and they think, oh, they've got so much money. It's not the case. The typical not-for-profit hospital, if their margin, loosely defined, if their margin is 2 to 3%, that's great. Yeah. Now, obviously, in the for-profit world, they have shareholder responsibility. It's typically much higher. It's in the teens, sometimes touching 20. But in the for-profit environment, because of the expectation of providing care to the entire community, margins are much thinner. And so typically those investments are the result of wise investments in the market, or capital reserves, or taking it out of operating income. So that's just a little bit of the expectation. Again, like you said, most people think hospitals are flush with cash, and it's definitely not the case. But let's talk about pricing. Hospital pricing, everybody's heard the anecdotes about the $4 Tylenol. Well, again, it's a misnomer, because we base everything off of charge master prices. And basically what that is just list price. Okay. Mm-hmm.
Like a sticker price on a car.
Yeah, exactly. Don't pay any attention to it because it's a joke. Typically those are 3 to 5 times what anybody actually pays. And they originally happened, years ago. They were inflated because of the cost plus reimbursement era, and payers, insurance companies use that kind of as the starting point for negotiation. Mm-hmm. And so nobody pays that. It's kind of like going to college these days. Nobody pays tuition rate. That's just a starting point. You start then looking at your scholarships, grants, whatever. But anyway, so in the hospital, there's really no market value at the list price, the charge master price. So you take that, and what really matters is the allowed amount, the patient responsibility, and then the plan payment. So let's kind of step down through everything. Let's start at the top with a typical charge. Let's round this off. Say a hip replacement, the list price is $45,000. Let's just go crazy there. Okay, the insurance adjustment, which they've negotiated, so it's a discount. Let's just say they negotiated a $38,000 discount on that. So now your allowed amount is $7,000. Okay, that's the number that you really need to start kind of looking at. Well, then based upon your plan, do you have copay? Do you have coinsurance? Do you have a deductible? Whatever. Then the next thing is based upon what the patient will owe. So typically, let's just say for grins, you're on an 80-20 plan. The insurer pays 80%, you're going to pay 20% out of pocket. So that $7,000 insurance is going to pay $5,600, right? So basically, you're going to owe your 20% coinsurance is $1,400. And so that's what matters. To any individual, what does it cost for me out of my pocket? And so again, don't look at that list price. Look at, what your insurer has negotiated and what your plan really entails. 80-20, 90-10, 100%. There's still a couple of those crazy plans out there.
Sure.
But that's what matters.
Okay. Excellent explanation. I wish that I had that as a young hospital executive.
Oh, no kidding. No kidding. Yeah. Well, but that's okay. For example, one of my hospitals, you look at top line revenue for the year. Mm-hmm. That hospital was $1.5 billion. Okay. people see that as like, holy cow, that's tremendous. But the average amount of that was truly collected was maybe 300 million, 20%. Collected. Then your expenses come into play. So that's why, that 300 million turns into a margin of, it could be 10 million. It could be 12 million.
Okay, Kevin, I love everything you've shared about price and quality and where those intersect. Is there a correlation? Is higher price, higher quality necessarily?
Not necessarily. Yeah. There are a lot of factors that, as we talked about, that go into setting pricing. And, the other aspect of that too is, a price might be higher because a facility has just recently invested in a lot of new technology. They're trying to build up their expertise versus a hospital that has got some legacy technology that's in a regular cadence. They've got physicians that have been highly trained on that. They basically worked through all the inefficiencies, and they're able to do that procedure, at a higher level of quality for a much lower price. Case in point, many years ago, I was at a hospital in Nebraska, and we'd been doing joint replacements for years, but we were looking to see how can we do this more efficiently and more effectively. So there was a physician in Florida that had a really interesting concept. He was all about patient education. So he bought a video company to create all this patient education videos. And so he created what was kind of it was a marketing package, but what really made it work was how he performed in his ORs. And so what he did, and hopefully this doesn't get too long for your listeners, but what he did is he would bring his knee replacements in on a Sunday, and he'd bring 10 to 12 in on Sunday afternoon. He'd provide them with that pre-surgical education, would feed them a steak dinner and put them up in a hotel on the night before. Mm-hmm. He would get patients in at about 5:00 in the morning on Monday morning. He would bring them in. He would line them up. He had 7 ORs. He had people in there. He had all of his first assists, his surge techs. He would go from one room to another. His first assist and surge techs were operating at the top of their license. They were doing what they could do. And what they could do was typically open up the case, open the patient up. The surgeon was only in each case about 15 or 20 minutes, operating at the top of his license. He would come in. He would take out the existing knee. He would put the new implant in. He would do everything he needed to do. He would leave and go to the next patient while his first assist would close. Boom, 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 boom. So he would do that. He would do 10 to 15 knees in one day.
Wow.
So he'd get all those folks out. Tuesday, he had the people up, and they all rehabbed together. And this was back in the old days when it was a 3 to 4 day. But he'd have them all together. It was like a support group. Everybody would go through therapy together and all that. And then, discharge those people on day 3. So he had developed that highly efficient model that drove down prices, but was incredibly, had an incredibly high quality. Mm-hmm. So that's just one example of where a lower price actually yielded a higher quality.
Oh, fabulous. Thank you for that example.
Yeah.
I don't think people comprehend how much fixed costs hospitals have, because you have to have a fully staffed emergency room. And because of the EMTALA laws, you can't turn people away. And you've got L&D staffed, and you've got trauma surgeons on call, and all of that costs money, which I wasn't planning on getting into side of service, but maybe this is a good time to explain that. That's why the hospital is where you go for, a heart issue, but that's not where you go for an ear infection, because it's just not the right side of care for that, because you're walking into a Porsche dealership for something that you should have gotten a Corolla.
Yeah. That's exactly right. It was funny. I was talking to a guy earlier this week, and he said, it's interesting that all this new technology and all these new pharmaceuticals that are coming out, they never cost less. Right. And I'm, that's exactly right. And And I had a discussion with a friend of mine a couple of days ago that runs a big cardiovascular service line at a very successful hospital out of state. And he was talking about, they are successful, but they're really in dire straits now because of reimbursement. Mm-hmm. And he said, we're going to have to look at, the level of care that we provide and, compare that to a guy I spoke with yesterday who runs a critical access hospital in New Mexico. Mm-hmm. And he said, we're trying to keep the lights on. We're trying to provide the basic level of care and to be able to stabilize somebody that comes into our ER to get them to Albuquerque that's an hour and 45 minutes away.
Yeah.
So back to what you were talking about, so many of these specialized hospitals, you see a lot of heart hospitals, you see a lot of orthopedic hospitals, you see the surgery centers, the reason those come up, a number of different reasons. Number one, you're focusing on one service line or one procedure or whatever. So hopefully you're going to get really good at it. Yeah. And you're going to have a lot of people specialized. You're going to get very efficient with that. And because of that, then you can negotiate oftentimes higher rates because you are doing a better job. So that's kind of the thing. So, like you said, you're not going to go to heart hospital for an ear infection. So, and that's something that, while those hospitals can make a lot of sense in particularly larger markets, they can be highly detrimental in mid-sized and smaller markets to the local hospital because what they're doing, they're cherry picking the high dollar cases. And so whenever those cases come out of your community hospital, then that's going to negatively impact the community hospital's bottom line.
Yeah. Oh, we could do an entire episode about the pros and the cons of that. Yeah. Wow.
Absolutely.
Yeah. Well, let's get into the new hospital pricing transparency, which I laugh when I say new because when I was in graduate school, we were talking about that. And then in the early 2000s, when I was at HCA, we thought we were the first to do transparency. And, now allegedly hospitals post prices online, but I use the word allegedly because it's really hard to decode. So what should consumers and employers know about that?
Yeah. Well, there's two different data sets. The machine readable files, that's the payer specific rates. And then shoppable services are more consumer estimates. Mm-hmm. And you if you go online and I'll tell you, most hospitals, this is not on the landing page, right? You're digging deep and you're finding very small font that says hospital prices. And it's not that they're trying to make it difficult. It's just what we talked about earlier. It's so confusing. The consumer gets in there and starts seeing it. They see that $45,000 hip replacement, like, holy cow, I can afford that. You got to step totally away from that, but it's a starting point.
Yeah.
So if you have multiple hospitals in your market, look at all of them and don't overwhelm yourself by trying to read every line. Pick one or two procedures. Look up those CPT codes, pick those procedures and compare those between hospitals because surprisingly, even hospitals across the street, there could be 300-400% variation between those hospitals for a wide variety of reasons. And so I got to be honest, even after 36 years, I can't tell you why. It's somebody, every CFO is different. Here's an example. I went to the hospital as CEO 30 years ago now almost. And hospital was not meeting budget. And so I start looking through there and I'm like, oh, why is that? And I'm not a finance guy, trust me, but I stayed in the Holiday Inn Express once. So I'm digging in and I look at the reserve column and the reserves are huge. And I go to the CFO and I said, why do we have all these reserves? He goes, well, we're in a small community in a poorer state. It's rainy day fund. I said, can we release some of those? He said, yeah, sure. So we released that. Guess what? We made budget. We blew budget out of the water and we still had plenty of money in reserves. So he's, ultra conservative. Then you get a liberal CFO that, I might keep 10% aside for a rainy day, which is probably not enough. So that's another thing. Everybody has their own quirks about how they lead and how they budget, and so that's going to affect what the consumers and the employers will see in all of that pricing transparency.
Yeah. And they're surgeons too. Having spent 5 years in anesthesia, we were obsessed with time so we could plan, so we knew how to staff, and what takes one surgeon 27 minutes might take another surgeon 42 minutes. Yeah. It makes it hard to price. I sound like I'm being defensive of hospitals, but it's just clarity in.
But you're exactly right, Amanda, because I've got real world examples of that just at my most recent hospital, between two specialists in the same practice doing the same procedure. One does it in 30 minutes, one does it in an hour and a half.
How are you going to price that?
Yeah, and neither one of them are wrong.
No.
I went to the group and I said, guys, why the variation between your two partners? And one of my close friends said, look, the one that's doing an hour and a half, he was trained, highly trained. He said, that's what he thinks he should do, and it's best for his patients. The other guy, he's a little bit more efficient. His patient quality is the same, and how do you go to a physician that might take a little bit longer and say, you need to shave some time off? That doesn't typically go well.
No, especially if they have good outcomes.
Right. Exactly.
Yeah. And then what about reference-based pricing? Where does it fit in your opinion?
There's pros and cons to that. The pros, you got some potential savings off of traditional PPO, and it's a little bit more transparent with employers. But the cons really go into, there are some insurance or some providers that refuse reference-based pricing. There's that balance billing risk that some providers may bill the patients for the difference. And you've got to have, there's a little bit more administrative burden on that. You've got to have a pretty robust stop loss and patient advocacy program for that. So, I think it's just something that you've got to weigh the pros and cons in your own situation.
Yeah. Yeah. That's great advice. And then what about things that people don't understand? Are there some common misunderstandings you can clear up for us?
Oh my gosh. Yeah. When I was making notes for this, I almost ran out of ink on this one. So here's just a few. First myth is the bill is final and non-negotiable. That is so far from the truth. Particularly if you're self-pay. You can go in there and let's go back to the crazy bill. You're getting the list price bill. Let's just say $1,000. I guarantee you that you can go in, you call the hospital finance department and say, hey, I tell you what, I pay for this out of my pocket. What if I paid you today $400? They're going to go, thank you so much. Because remember what I said earlier, that $1,000 on the whole, the hospital might be collecting 20% of that. So your $400 offer is golden. They're happy about that.
Yep.
So
that's the number one thing. If you have the money, call and offer to pay in full today at a drastically reduced rate.
Absolutely. Absolutely. Okay. Myth number 2, in-network means affordable. Absolutely not. In-network is the negotiated price that the insurance did, and within a certain network of providers. You might be able to go out of network and get it cheaper. You just have to, all it costs you is some time. And so it's, if you're looking at a major high dollar intervention, you probably should spend the time. And that's the thing. Most people just don't think about shopping healthcare rates.
Yeah.
The whole transparency move lately, I think the industry thought people would take advantage of that, and they really aren't. And so I think that's something that people really need to spend time on.
Yeah. Especially things like a knee replacement or a hip replacement.
Oh gosh, yeah.
Shop it.
Yeah, absolutely. Okay. Myth number 3, emergency room bills can't be negotiated because of urgency. Not true. The No Surprises Act of 2022 protects patients from most surprise billing. And out of network emergency care has to be billed at in-network rates because, hey, my plan may cover me here within my 50-mile radius. I don't stay in the 50-mile radius. I might go, hey, I might go to the coast. I might go see my kids on the East Coast. And if I have an issue and have to go to the ER, it's not my fault. And so that has to be covered in network rates. And so you have the opportunity to definitely shop that. You can dispute those bills. And oftentimes those get changed.
Ooh, can I add something to that one?
Yeah, please.
So first call the ER group, the radiology group, whoever it was, try them first. If that doesn't work, call hospital administration. I chose your facility because you were in network and I got to your facility and got an out network position. That hospital administrator is going to call that group and that bill's probably going to go away.
Yeah. You're exactly right. That as a hospital administrator, we don't like those calls coming to our offices when patients are unhappy, and particularly when they're unhappy about their billing.
Yeah.
And so, I would get those calls, say, let me see what I can do. I'd get on the horn with finance and say, guys, come on, there's got to be something we can do with that. Okay. Myth number 4, medical billing codes are accurate. Ha ha. That's a joke. About 80% of those bills contain mistakes. And so, you take a look at your bill and I guarantee you start going through that, you're going to find things that, I know, I was lucid throughout my entire stay. I never got that. Here's what happened. It's not because hospitals are trying to stick it to you at all.
No.
You got to think about the people who are documenting your care. You've got nurses, you've got x-ray techs, you've got all these other people, you got physicians who are documenting their care. You got to think about what they're doing. They're taking care of you. And oftentimes nurses are taking care of 5, 6, 7 other people. It's not an excuse. It's just a reality of today's market with our nursing shortage, and nurse ratios are stretched thin. So, they may have stepped out of your room and with full intention of going directly to your chart to document. And one of their other patients had an episode that they had to go deal with. So they don't get back to your chart for maybe 45 minutes to an hour. And they're like, oh my gosh, what did I do? What did I give to Ms. Smith? And I've got to think about this. And so, mistakes happen.
Yeah.
And it just does. They just do because people are human. We put in a lot of interventions to prevent that. Obviously, scribes, obviously, standard order sets, things like that. But still, it happens. It just happens. And oftentimes, whenever that gets out of the clinician's hands, it goes into billing and coding. A coder might see something a little bit differently based upon what was written. So they put a different code in that kicks a charge up. So all that to say, look at your bills closely.
Yeah.
And then finally, the one that a lot of people really are concerned about, not paying will immediately ruin your credit. Not the case anymore. Medical debt under $500 is no longer reported, and paid medical debt is removed immediately as of 2023. So, I'm not saying, hey, don't pay your hospital bill, don't pay your physicians, but it's not going to totally damage your credit. And hospitals also, we recognize, particularly the not-for-profit, what we do is about people. We're tax exempt for a reason. So we're trying to help people. We don't want to put people, into bankruptcy by any means. And so we obviously will work with people. Payment plans are very, very common. Charity care is always available. There are other things now. One of the companies that I'm advising, what they do now is they're working with large hospitals and systems on these bills for people who have no coverage. And what they're doing is they're taking those and, surprise, they're using AI technology but they're going to foundations, they're going to pharmaceutical companies and really trying to mine all of these discounts that are out there or grants or whatever to help pay for that. So, it really hurts my heart when people say, hey, I've got something going on with me, but I can't afford to have it taken care of. Yeah. Well, you got one body, health is honestly the most important thing. And as you get older, you figure that out even more so. So go and have something taken care of. The finances should be, a secondary issue. So,
yeah, that's really good advice. We did a show recently about the 501(r) programs with hospitals, which I never even knew about. So lots of resources out there. Well, Kevin, you've convinced us that hospitals are open to conversation. They're not this big bad boogeyman. So if somebody's heard you today and they're like, okay, I think I need to build a relationship with a nearby hospital, where do they start? Who should be in the room? What should they look for?
Yeah, glad to. Okay, start with data. Look at your own loss data within your organization and identify 5 or 10 of your highest cost procedures and volumes. And then, look at your current costs versus market rates, because they're out there. You can find that. And then find, say 2 to 3 high quality, cost effective hospitals in your area. And then start with one hospital, start that conversation with one hospital, see how that goes. And then, talk to the other ones and compare. You look at the large multi-state, multinational organizations. Let's just say Walmart, for example. Walmart has taken the center of excellence to a real art form. Yeah. Walmart patients or Walmart employees, if they need, let's go back to our friend, the knee replacement. If they need a knee replacement, Walmart has negotiated prices at a few of the top hospitals in the country. They will pay your travel costs to go to this hospital to have your procedure done, soup to nuts, your recovery time, and then get you back home. It's cheaper for them to do that than to say, hey, go to your local hospital. They've researched this. Walmart's not stupid. They've researched this and it makes sense for them. And so why can't, an employer, say here in Waco, Texas, do the very same thing? If you've got a lot of employees and you've got a pretty significant healthcare expense in your organization. So that's where you start. Okay, so who should be in the room? On the employer side, get your CFO or your benefits guy in there. And I will say it's worthwhile investing in a broker or a consultant with some of that direct contracting experience, because, I'm sure your CFO is really brilliant in industry X. Healthcare is unlike any other industry, trust me. And so, we've got our own language, we've got our own abbreviations, we've got all that. You need somebody that can speak healthcare language to you, that can translate that to you. And then, never hurts to have legal counsel close by.
Yeah.
And then on the hospital side, make sure that you've got their contracting and network development people. You want somebody that has a lens into the hospital's quality.
Mm-hmm.
You want to know, hey, what is your infection rate on that knee? What's the return to work data on that? And to get a revenue cycle person in there, for to talk about how that claim's going to be administered and all of that. So that typically, if you start with that, you'll be okay.
Yeah, that's all really good advice. And especially the broker part. And I will add that if your broker gets squirrely or acts like you don't need to do that, red flag. Find a broker that is happy to have those conversations and be a resource.
Yeah, absolutely.
And then what about on the employee side? What can employers do to help their employees work better with the hospital partners? Understanding in network, getting estimates, even choosing the right side of service.
Yeah. Yeah, that's something, I will be honest with you, most employers do a really terrible job of. And
it's hard.
It's really hard because, the employer, they're spending so much money on health insurance. They think turning it over to brand X or whoever, that's sufficient. It's really not. You need to help educate your employees. During that annual enrollment time, talk about the differences in network. You know, if you negotiated with one hospital system over another in your community, tell them why.
Yeah.
You know, tell them, hey, it was a cost issue. It could have been a quality issue, you know, and have the data to back that up, you know, and highlight your preferred partners. Share the cost comparisons, you know, just be really open with it and have some real dollar examples. Say like, you know, you can get your knee replaced at brand A hospital for $7,000. And with our plan 80/20, it's going to cost you $1,400. Or you can go to brand B, same quality, for, you know, a $6,000 or let's say $5,000, and you're only at $1,000. You know, give some real world examples, and even having like, you know, an easy one pager how to use your benefits. Because like I said, I've been doing this a long time, and I make numerous mistakes in using my own healthcare benefits. And so it's going to happen. Then, you know, talk to your folks about, you know, what does in network versus out of network really mean? Mm-hmm. You know, and like I said earlier, out of network could mean a lower cost at equal or better quality, but that employee needs to do a little bit of research on their own. And then, you know, teaching the employees the right questions to ask to get those upfront estimates. You know, like, what's the CPT code for my procedure? You know, which is, you know, everything, trust me, everything has a CPT code, and everybody, you know, for you, you know, ask what's the contracted rate with my insurance? You know, what will my out of pocket be after my deductible? Ask those specific questions. And something a lot of people forget, does this include the facility fee, or is it and the physician fee as well? You know, is the FRO fee included? And so, you know, give people the tools, show them the transparency websites, you know, give them a direct phone number to your benefits team so that they can get to an expert quickly. So those are just some of the things that an employer can really do to help their employees.
Yeah, those are all really good tips to really educate and help people advocate for themselves. You mentioned data. Are there certain data sources where people can go to for quality measures, pricing information? And, you know, unless you're in the industry, you don't know where the good facilities are, or more importantly, the bad facilities. So,
yeah. Well, and you can do this not only, you know, for hospitals, but ambulatory surgery centers, nursing homes. You go to the Medicare website, the Center for Medicare and Medicaid Services, and there's a star rating for all facilities. 1-star bad, 5-star good. And so, and they will have you know, you can drill down to things like mortality and readmission rates, patient experience scores, so how well they treat you. And then, of course, the safety metrics and overall infection rates too. And then there is a group called Leapfrog, and they do hospital safety grades, and you're graded A to F. Don't go to an F facility, go to the A facilities. You know, and they're a little bit more focused on infection rate, patient, you know, errors and injuries, and they're updated twice a year. You know, I know it's honestly, it's a really arduous process for Leapfrog for hospitals, but it's well worth it. You know, it really is. And then, you know, you go to consumer magazines like a U.S. News and World Report hospital ranking. It is data driven. I'm going to be totally honest. There's some marketing in there too, you know, and surprise, the hospitals who get those designations from either U.S. News or Newsweek or whatever, in order to promote that and use those badges, they have to pay for it. So, you know, take that a little bit with a grain of salt. CMS and Leapfrog are really more directly data driven, but U.S. News and World Report and Newsweek, they're nice to have. I mean, trust me, my hospitals, we always did that because it's something that's more recognizable versus CMS or Leapfrog to people. Everybody knows U.S. News and World Report. And then finally, the Joint Commission, which you know, is the accreditation body for the vast majority of hospitals. You know, that is, I mentioned arduous for Leapfrog. Joint Commission if you're lucky and you do well, it's an every 3-year process. that whenever your accreditation or your survey window comes up, you know when that's going to be. You start the planning process for just your survey at least a year in advance. So, it's almost like running for office. You're constantly running for office. You're constantly preparing for survey. And the thing about it, that's the right thing to do, because there are so many regulations within the Joint Commission, and it's very detailed. And if you're meeting all of those, you're an amazing hospital. You are providing high quality care. You're communicating well with your patients. You are providing a great patient experience. So why wouldn't you do that anyway? But it does take a lot of time and effort. And then, of course, every state, each state has their own, the Department of Health. You have to go through surveys for them too. So you can look that information up as well.
And then any good resources on pricing?
Yeah, there are a few. There's like hospital price transparency files. That's been required since January 2021. Fair Health Consumer stuff. That's using like an independent cost estimator. And then employer-focused resources. A Purchaser Business Group on Health, PBGH. That's an employer coalition that focuses on value-based care. And there's lots of resources around direct contracting and peer networking and things like that. The National Alliance for Healthcare Purchaser Coalitions, those are regional coalitions, but kind of the same thing, sharing best practices. And then there's one, the Catalyst for Payer Reform. There's research and tools on payment reform, and there's scorecards on different markets and concentrations and things like that. And then, of course, you can always, look to a consultant for support, and like you said, look to those that are willing to really dig in and help you, and don't promise a cookie cutter approach. Get somebody that is willing to take the time to look at your organization, your market specifically, and really, give you the best level of advice. They might be independent. It could be a third-party administrator. It could be, a patient advocacy organization or something like that.
Yeah. Well, Kevin, you have been a wealth of information. I feel like you just gave everybody all like the insider secrets, like how hospitals aren't scary and they're not bad, and they're be your partner. So thank you for that.
Yeah. There's a couple of, just kind of wrap up for you, Amanda. There's a few things that I would say that just summarize what we've talked about. Number one is start with your data. Understand the current costs and the utilization. I mean, you've got to know where you are to go forward. Then next, use quality. Use the quality measures to find those high performing facilities and providers, and not just the low price options. It's kind of like, hey, you might want to spend a little bit less money, but you've got to look at the long-term episode, because somebody's health, this is silly to say, it's a lifetime. And so you might save money now, but the money you save now might generate a much higher cost at a later date. So just evaluate that. Definitely leverage the price transparency to negotiate and identify your partners. Connect with employer coalitions, get best practices, talk to your peer groups. And then, as we said earlier, really invest in that employee education and helping them make really, really sound decisions for their health. Because, the better decisions that your employees make, hopefully that's going to cause less utilization for healthcare as a whole, and it will help you to drive down your costs. So there you go.
Amazing. Thank you so much for all the information, and thank you for your time.
Absolutely. Really enjoyed it, Amanda.
Huge thanks to Kevin Stevenson for breaking down how hospital billing really works and how employers can partner with hospitals for better cost and better care. Thanks for listening to the Generous Benefits Podcast, where we keep it practical, personal, and people first.